Welcome to part 4 of diabetes. This PowerPoint is going to focus on the treatment of diabetes. Managing diabetes is a lifelong process. People who are type 1 diabetics, because they develop diabetes at such a young age and produce no insulin, will require very strict monitoring of their blood glucose levels and very tough management regimens to prevent complications. Type 2 diabetics, because they do produce some insulin, usually do not require as strict of management, but because of this, many times they take that to mean they do not need to manage their diabetes at all. This lack of management causes significant complications. But no matter what type of diabetes a person has, the goal is the same. We need to normalize insulin activity and blood glucose levels to reduce complications. Ideally, we want to see the treatments maintain a hemoglobin A1C level less than 6.5%, ideally less than 5.7. How we get a person to that level depends on the type of diabetes they have, the severity of their diabetes, and how well the person follows the regimen created for them. The regimen for diabetes includes nutrition, exercise, blood glucose monitoring, medication, and a lot of education. Nutrition is a major component of diabetes management and oftentimes requires a lot of education and a lot of reinforcement. The goal of diabetes nutrition is to make sure the caloric intake is enough to attain or maintain a reasonable body weight. Remember, type 1 diabetics can lose a lot of weight very quickly, and type 2 diabetics have overweight and obesity as a contributing factor. We also use nutrition to control blood glucose levels. If the blood has too much glucose, which is a sugar, we need to limit the amount of sugars the person is taking in. Also, because diabetes has major effects on the cardiovascular system and blood vessels, we need to help normalize lipid levels and blood pressure, which we can do with low fat and low sodium diets. As nurses, we have a big part in helping our diabetic patients with their nutrition. We need to be knowledgeable about dietary management and be able to communicate those needs with the patient or refer them to a dietitian or diabetic educator to help them really understand the nutritional needs they have. We also do a lot of education and reinforcement on our patients' understanding and following of their diet. Think about kids and teens who are type 1 diabetics. They know they are sick, but they're going to go out and eat with their friends. They're going to go to birthday parties where there's food they shouldn't be eating, and it's going to make them feel more different than they already are. So a lot of times kids don't like healthy foods and they eat those bad foods when they go out to parties and to restaurants. That's why we have to reinforce the diet over and over again, and we have to make a really big deal out of the small wins they do have, like choosing healthy foods instead of sugary foods when they go out to eat. We have to be their cheerleaders and really support and really encourage them. When we help our patients with their nutrition, we need to take into account their food preferences, their lifestyle, their usual eating times, and their cultural or ethnic practices around food. Just because we have an idea of what American healthy foods are doesn't mean our patient wants to eat them, and there's a lot of American food that other cultures will not eat. Typically, a diabetic diet is going to have an amount of calories per day that we suggest the person eat. In the hospital, we see a lot of 2,000 calorie diabetic diets. They're sometimes called ADA diets that are ordered for the patient. This means every day we need the patient to take in about 2,000 calories. Those calories are going to get divided up into carbs, fats, and proteins. We want the person to take in about 50 to 60% of their diet in healthy carbohydrates, like whole grains, whole fruits, and non-starchy vegetables. We want them to have about 20 to 30% of their diet come from healthy fats, like olive oil, nuts, avocado, and fish. Some of these fats have protein as well, which is great. Protein should make up about 10 to 35% of the diet, and we want to emphasize that there are a lot of non-animal sources of proteins, like legumes and whole grains, that also add fiber to their diet. Raw or whole foods are best for diabetics because they have a lot of fiber, which is going to slow absorption and keep the person feeling fuller, and it's going to decrease the glycemic response in the body. We want to discourage highly processed foods that tend to be high in sodium and carbs. Sugary foods like ice cream, cakes, and candy are all very high in sugar and will raise the blood glucose levels very quickly. We also want to encourage avoidance of alcohol, which is actually a type of carbohydrate. Exercise is a great way to lower blood glucose levels, especially in type 2 diabetics. Exercise and diet in type 2 diabetics can actually control blood glucose levels and are the first-line treatment for type 2 diabetics. Exercise also aids in weight loss and lowering stress level, which helps lower glucose levels. Exercise also helps lower the risk of cardiovascular disease, which is a major complication of diabetes. In type 1 diabetics or type 2 diabetics who are using insulin, exercise can cause some issues. First, exercise causes the cells to need and use more glucose for energy. In diabetes, the cells are already having a hard time getting their glucose levels, so exercise can cause the cells to starve and to die. Also, exercise lowers blood glucose levels, which is great, except it could cause a person to go hypoglycemic during or after the exercise, which would be a bad thing. Anyone who takes insulin or any glucose lowering medications should have a pre-workout snack with 15 grams of carbs. They should also check their blood glucose levels before and after exercise. People with type 2 diabetes who do not take insulin or glucose lowering medications may not need to have a snack, but they should definitely be checking their blood glucose levels before and after exercise and monitoring for any symptoms of hypoglycemia. All right, now let's discuss injectable insulins. As you can see from the slide, there are a lot of injectable insulins. Some of these you already know from class or clinicals. Injectable insulins are divided up into classifications based on how rapidly they act. First, we have rapid-acting insulins like Lispro, Aspart, and Glucosamine. These all act rapidly to lower blood glucose levels, and they start to work within about 15 to 30 minutes, and they peak in 1 to 2 hours. This means we need to make sure these patients have their meal trays ready to go when we give them their insulin so they do not become hypoglycemic. Next, we have short-acting regular insulin. Regular insulin starts to work in about 30 to 60 minutes, and it's going to peak in 2 to 4 hours. So it takes a little bit more time to kick in. Regular insulin can also be given by IV, so you see this type of insulin used in the emergency departments and in ICUs a lot. Rapid and short-acting insulins are used for mealtime coverage, with Lispro and regular being the most common ones you see. Next, we have intermediate-acting insulins like NPH. These insulins start to work in 2 to 4 hours and peak in 8 to 10 hours. Intermediate insulins are often used in conjunction with rapid or short-acting mealtime insulins to have a longer daytime blood glucose level control. Lastly, we have long-acting insulins like Lantus and Levemir. These insulins are great because they act like the body's basal insulin production, causing lower blood glucose levels for up to 24 hours. People who take these insulins tend to have a lower blood glucose level and lower mealtime coverage needs with those rapid and short-acting insulins. Now, I want to be very honest with something. People may take a combination of these medications at home depending on their needs, which could change with stages of life. In the hospital, depending on why they're there and how their blood glucose levels are doing, we may have to take them off their normal insulins and treat them very differently than they're used to. This can cause some anxiety for them, and nurses really need to educate them on why we're changing their insulins. Here's the same information on the last slide, just presented in a different way to help you understand the peaks and durations. On the last slide, I mentioned how we take people off their normal insulins when they're hospitalized. One reason for that is the medications we're giving. IV fluids may have dextrose in them, which is a sugar. Some antibiotics are mixed in dextrose, and some medications like steroids actually increase blood glucose levels. That's going to change the body's insulin needs, and they can change those needs hourly depending on the medications we're giving. If we gave someone a long-acting medication, but then we stopped their IV dextrose fluids, we could inadvertently cause severe hypoglycemia. The disease that brought them in could cause hyperglycemia, like an infection, and once we start treating the infection, their blood glucose levels might drop quickly and their insulin needs are going to change just as quick. We have to be very careful not to cause hypoglycemia in our patients, so we do mess with their insulins, unfortunately. Insulins can be given a couple of different ways. We give it in the traditional subcutaneous way, like we've been doing in skills and what you've probably been doing in clinicals. We draw up the insulin into an insulin syringe and we administer subcutaneously. There are also insulin pens that can be used, usually not in healthcare settings where pens have the insulin preloaded in a syringe and we just turn the dial to the amount of insulin that needs to be administered, attach a new needle, and we give it subcutaneously. Then we have insulin pumps, which are devices that are attached to the patient at all times that administer insulin at either intervals like meal times or a slow continuous administration or both. And some insulin pumps can actually connect to a continuous blood glucose meter that's attached to the person's body, and the continuous blood glucose meter and the insulin pump communicate with each other to deliver the correct amount of insulin all day long. We do have to be mindful that anywhere we're giving insulin can cause local skin reactions, including allergic reactions. If our patient has any of these types of insulins and they're new to it, we have to educate them on all of it. In type 2 diabetes, we have oral medications to help control their blood glucose levels. We use these medications when diet and exercise are not controlling their blood glucose levels enough. The reason why we can use oral antidiabetics in type 2 diabetes is because they still produce some amount of insulin. There are several different categories of oral antidiabetics, and they have different actions. Some work to decrease hepatic glucose output, some decrease glucose absorption from the GI tract, some help the cells accept glucose, and some help the pancreas decrease glucagon secretion and increase insulin secretion. I should mention that oftentimes a combination of oral antidiabetic medications are needed to help lower blood glucose levels because we can affect multiple areas in the body with multiple medications. As nurses, we need to monitor blood glucose levels for hypoglycemia and other potential side effects that are medication specific. We do have to do a lot of education regarding the use of each of the medications and their side effects. Two of the more common anti-diabetic medications are metformin or glucophage and glyburide or diabeta. These drugs are so common that they actually make them in a combination pill of metformin and glyburide together. Metformin works to inhibit production of glucose in the liver and increases the cell's sensitivity to insulin. It does have a risk of hypoglycemia and is contraindicated in patients with impaired kidneys and livers. It also has a major drug-to-drug interaction with IV contrast. We cannot give metformin for 48 hours after IV contrast or it will cause significant kidney damage and kidney failure. I'm talking complete shutdown of kidneys. Glyburide works by stimulating beta cells in the pancreas to secrete more insulin and can be used in combination with metformin or insulin to improve blood glucose levels. It does have a risk of hypoglycemia, and it does have a drug-to-drug interaction with NSAIDs and warfarin. If a person is taking glyburide and beta blockers, the normal warning signs of hypoglycemia may not occur, and the patient could develop severe hypoglycemia before anyone realizes it. And this is the end of diabetes.